So in chapter 21, we're going to talk about respiratory function and alterations in gas exchange. And we're going to start with the anatomy of the respiratory system. Anatomically, we can divide the respiratory system into upper and lower airways. The upper respiratory tract is made up of your nasopharynx, oropharynx, and laryngopharynx, including like the nasal cavity. And the lower airway structures, we call this the lower respiratory tract, includes the larynx and everything below that or inferior to that, right? So the larynx, the trachea, the bronchi, bronchioles, alveoli, that kind of stuff. That's part of your lower respiratory tract. So looking at this, just sort of a summary of the anatomy here, you guys. You can see our nasal cavity here with our nasal concha. We got our pharynx, which is this muscular tube in the back of the nasal and oral cavities. So we have the nasopharynx, oropharynx, and laryngopharynx. And that's the upper respiratory tract. That's it. So if someone has an upper respiratory tract infection, you're talking about an infection that it would include any of these areas. Now the lower respiratory tract includes the larynx and below. So we have our larynx here, which is basically the voice box. It's got our vocal cords. It also has our glottis, which we'll talk about in the digestive system, helps you defecate. And then just inferior to the larynx, we got our trachea. The trachea eventually gets down in the thoracic cavity where it branches into two. We got the right and left main bronchi, or primary bronchi. Those right and left main bronchi branch again into what we call secondary or lobar bronchi. And every secondary bronchus or lobar bronchus goes to a lung lobe. Okay, so we know that our right lung has 3 lobes, right? So we have 1, 2, 3 secondary bronchi or lobar bronchi, and our left lung only has 2 lobes. But beyond that, you guys, then we have what are called the tertiary bronchi, and those tertiary bronchi, also called segmental bronchi, go to the bronchopulmonary segments you find throughout the lungs. And each bronchopulmonary segment is its own distinct little area of tissue. Okay, so they're all separated by some connective tissue, and they're going to have their own branching pattern within that. Now, we'll first talk about the trachea in more detail here. So the trachea is about 11 to 13 centimeters long. It's got cartilaginous rings, so the hyaline cartilage in the trachea, the C rings, help maintain the patency or openness of that trachea. They can come in different sizes and shapes. They can be U-shaped, D, or C-shaped. C is the most common, or triangular and elliptical. So just looking at the trachea here, you guys, remember it's 11 to 12 centimeters or so. All of these are the tracheal cartilages or C rings, but they're incomplete. That's why we call them C rings. So if you look at a cross section of the trachea here, you can see it kind of forms a big C here. Those cartilages do. And their main goal is to really just help maintain the openness of that trachea. But the very posterior side of the trachea is actually made of smooth muscle. In fact, it's a smooth muscle called trachealis, which is under autonomic nervous system control, which can help regulate the size of this trachea. So you can help regulate how much air flow can go into or out of through that trachea. Once we get towards the end of the trachea, what we find then is there's a carina. So the carina is this place where it splits. Now the carina is clinically significant because it's a very sensitive area of the trachea. There's a lot of nerve endings here at the carina. So if someone inhales any foreign debris and it tickles the nerve endings on this carina, then they can have a cough reflex. And you'll notice that we have the right and left main bronchus, which are primary bronchi, which is the first split here. The right main bronchus is actually larger and steeper than the left. So this means that you're more likely to inhale something into the right lung rather than the left, because the airway here on the right side is larger than it is on the left. In fact, one thing that's also important to note, you guys, is that for the epithelium that lines the spaces of your trachea and larger bronchi, it's a pseudostratified ciliated columnar epithelium, which is the purpose of this is to help trap debris, and then the cilia will all wave that debris up and out of your airway. Okay, and we'll come back to this later. Now, going down deeper, like microscopically in the airways, what we find then is that those bronchi keep branching. You know, primary, secondary, tertiary, but then it even goes quaternary, and it continues to branch for more than 20 times until you get to the microscopic level. Eventually, you get to these things called bronchioles. Bronchioles are similar to bronchi, but they don't really have a lot of cartilage around them, so they're more of a softer structure. We have terminal bronchioles, which are near the end, and then we have, second to terminal bronchioles, that'll branch into respiratory bronchioles, which then lead up into what's called an acinus. You know, acini means grape. So these kind of look like grape-like clusters. And each of these grape-like clusters is made up of an individual alveolus. So you have an alveoli in here. And the alveoli are basically just like the air sacs of your lungs. So what these alveoli are then are basically the places in your lungs where a significant amount of gas exchange occurs. Because each alveolus is made of a simple squamous epithelium, the walls of the alveoli are really, really thin. And by having very thin walls, it allows for gases to move across the wall of the alveolus really quickly. In fact, if the surface area inside of the alveoli in both of your lungs, they say is close to about the size of a tennis court or so. So there's a lot of surface area inside your lungs, and it's all locked up in these circular structures called alveoli. Now, every single alveolus has an associated capillary bed, right? Because we know that the right side of the heart pumps deoxygenated blood towards the lungs through the pulmonary arteries. Well, those pulmonary arteries will eventually branch into smaller and smaller vessels that lead into capillaries that surround the alveolus. Those capillaries that you find around each alveolus are involving the gas exchange there, so you can absorb oxygen from the air in the alveolus and then help eliminate carbon dioxide from your blood in the capillaries near the alveolus into the alveolus there. And so gas exchange occurs mostly in the alveoli here. What happens then is that for those capillaries, they eventually reconverge into veins, and those veins converge into pulmonary veins, which carry that oxygenated blood back towards the left side of the heart, where that oxygenated blood then can be distributed through your body through the left side of your heart. So inside of each alveolus, we have three main cell types. We got macrophages, type 2 cells, and type 1 cells. The role of these macrophages is basically just to phagocytose or engulf any debris that you might inhale to help remove it. In fact, I was working with this stuff this weekend, you guys. It's called precious metal clay. And this precious metal, it's basically clay, right? And you can make stuff in clay form. But when you take a blowtorch to it, you can actually burn off the clay material, and what's left is metal. So we were making like jewelry and stuff. In fact, I made a ring. I'm not wearing it because it turned out really bad, but it was kind of cool. The problem though, I wasn't wearing a mask, so I was actually inhaling a lot of this debris, and then later on my lungs were hurting, and I was thinking, oh no, what did I do? I must have inhaled like a bunch of silica or something, or maybe even metals, which are pretty difficult to remove, because these macrophages, they try to remove like metal and silica, but those are difficult to break down. Organic material, on the other hand, is much easier to break down. Carbon-containing materials, maybe like skin cells or dust. That's easier to break apart by these macrophages. These type 2 cells produce surfactant, and the purpose of surfactant is it helps lower the surface tension of water. So it prevents water from being as sticky. That way the walls of your alveoli don't stick together and they remain open or patent. Now these type 2 cells are also involved in gas exchange because they're thin. And the type 1 cells, their sole purpose is gas exchange because they're also very thin. Okay? But the type 2 cells, you guys remember, those produce surfactant, which helps reduce the surface tension of water in the alveoli. It turns out, you guys, that surfactant is basically like soap. Soap reduces surface tension, but surfactant also has antimicrobial properties too, because it can help break apart the phospholipid bilayer of microbe cell membranes, because it's surfactant, right? It can break those apart. And although it helps reduce surface tension of water in your alveoli, it does help prevent infection. Now, for our lungs, blood supply comes from two sources. Now, we get deoxygenated blood from the right side of our heart, getting pumped to the lungs through the pulmonary arteries, but we also have these things called bronchial arteries. Now, these bronchial arteries are small branches of the thoracic aorta, and those come off right out of the thoracic aorta, and they supply oxygenated blood to the lungs itself. So for some of the larger structures in your lungs, they need to get their own blood flow, right? Just like how the heart needed its own blood flow, even though it's pumping blood, the lungs need their own blood flow, even though they're involved in gas exchange, because not all the cells are getting, a sufficient amount of oxygen from the airways itself. So what we need then are these bronchial arteries that supply small amounts of oxygenated blood to structures like pleura and larger lung tissues that don't participate in gas exchange. That's the bronchial arteries, okay? Whereas the pulmonary arteries bring that deoxygenated blood from the right side of your heart towards the lungs, which becomes oxygenated, and then that blood then is transported back towards the heart through the pulmonary veins carrying that oxygenated blood. Capillary networks in like neonates, young children, and elderly are less abundant, so they're going to have more difficulty with gas exchange. Now, what's interesting, you guys, is that at any moment in time, only 25% of your lung tissue is perfused. You know, there's a lot of lung tissue there, but there's only a finite amount of blood that can be pumped to the lungs. So that means that each lung is only getting 25% of its tissues have blood flow. So you might wonder, well, how does your body like choose what parts of the lung get more or less blood flow? Well, the mechanisms here are based on what we call ventilation-perfusion coupling, okay? Where if you have very well ventilated alveoli, like if you have alveoli that are getting a lot of airflow, then it would make sense to send a lot of blood flow to those alveoli because then they can participate in gas exchange, right? But what about parts of your lung that maybe they're plugged due to mucus, maybe they're collapsed due to like lack of surfactant, or there's some other structural anomaly where the alveoli isn't getting a lot of airflow? Well, it wouldn't make sense to send blood to an alveolus that's not getting a lot of airflow. So what happens then is that we can actually divert blood away from poorly ventilated alveoli and send that to the best ventilated alveoli. The ones that get the most airflow get the most blood flow, right? It makes sense. It's like the biggest return on your investment. Okay, so what's nice is that although only 25% of your pulmonary tissues are perfused at any moment in time, it's the most efficient ones that are perfused. The ones that get the most airflow are the ones that are most highly perfused. And so it's a really nice way to increase the efficiency of gas exchange in your lungs. So this is done in a couple ways, you guys. For one, you can recruit capillary vessels to distend. And by distending, they're kind of vasodilating. And by vasodilating, you're increasing blood flow. Okay? Remember, there's also precapillary sphincters. Those precapillary sphincters can regulate blood flow to a capillary bed. Well, if you relax those precapillary sphincters, then you're going to have an increase in blood flow to that capillary bed. Okay? So it's kind of like opening the floodgates, right? And you want to open the floodgate wherever the alveolus is getting the most amount of airflow. Now, this is what is shown here, you guys. So like with a normal alveolus, it might get just sort of, it's going to have this sort of structure of capillaries here. Now with recruitment, what this means is then you can actually help increase blood flow to some of the capillaries here that would otherwise be constricted. Or these capillaries can increase in size through distension. And distension relates to things like blood pressure, but you're also changing the structure of the tissue itself. So this takes a little longer, but these are ways to improve gas exchange in your lungs. Because if an alveolus is well ventilated, you want to increase blood flow there. So some different factors that affect pulmonary circulation would be things like blood pressure, right? You don't want blood pressure to be too high in your lungs, because if it's too high, then you can start to force fluid into your airways. And we learned about that earlier with the capillary hydrostatic pressure, where there's a tendency then for fluid to be forced across the capillary wall via filtration. But in this circumstance, you don't want water being forced into your alveoli, because that would diminish gas exchange. So we got to maintain blood pressure at a fairly constant level, but not as high as like systemic pressure. So pulmonary blood pressure is much lower than systemic blood pressure. We also want to maintain our colloid osmotic pressure, right? So colloid osmotic pressure is basically due to albumin in blood, how you can reabsorb water from your tissues back into your bloodstream. And by having a sufficient amount of colloid osmotic pressure, it helps prevent things like pulmonary edema or the accumulation of fluid in your lungs, okay? You don't want capillaries to be too permeable either, right? If capillaries are too permeable or too leaky, then you're talking about fluid that could enter your lung spaces. Or you get a reverse circumstance, like bacteria could make it into your bloodstream too easily from your lung spaces. Now, when capillary hydrostatic pressure exceeds this colloid osmotic pressure, you guys, then what we'll find then is that fluid moves from capillaries into the interstitial space. That's what we call pulmonary edema. So your lungs start kind of accumulating a lot of fluid when these pressures are not matched. So normally you want to match your blood pressure with osmotic pressure here. That way you don't have an excessive amount of fluid building up in your lungs. However, our lungs do have a lymphatic system. So there is lymph in lungs, so that if this fluid does accumulate, that fluid can be removed by your lymphatic system away from your lungs. So if this isn't controlled, you guys, like if left unchecked, what we'll find then is that fluid can enter the alveoli, causing alveolar edema, and that leads to poor gas exchange. Because if you have fluid in your airways, it's going to be difficult for water to it's difficult for gases to move across that additional water barrier. So ventilation is just the word we use to describe airflow into and out of your airway. So if you're ventilating, what you're doing is you're inhaling or exhaling. Those are both processes of ventilation. Okay? And the purpose of ventilation here is to maintain normal oxygen levels in your blood, as well as help remove excess carbon dioxide from blood. And so these gases only move via diffusion. There's no active transport here. I mean, it takes energy to ventilate. Like it takes energy to inhale, because you have to use muscles to contract and help expand your rib cage. But it doesn't take any energy, excess energy, like ATP, to allow for gases to move across the alveolar membrane. Gases only move via diffusion. So if the concentration of oxygen is higher in the alveolus than your bloodstream, then oxygen will move into your bloodstream. Or if the concentration of carbon dioxide is higher in your bloodstream than in the alveolus, carbon dioxide then will leave your bloodstream and enter the alveolus, so it can be exhaled, right? It's just due to diffusion, moving from high concentration to low concentration. So there's different measures of ventilation, like lung volumes and capacities. And what this shows you guys are some spirometric data. And so what we see here then is total lung volume from 0 to 6,000 milliliters, or 6 liters, over time. So we can do this, kind of look at how gases are moving into and out of the airway over time. So these smaller changes in lung volume here, we call tidal volume. This is like normal, quiet breathing. If you're just, what you guys are probably doing right now, you're not taking deep breaths, you're necessarily exhaling very deeply. You're just having like normal, quiet breathing, which doesn't require like large changes in your thoracic volume. This normal quiet breathing we call tidal volume, and it's typically around 500 milliliters or so. So half a liter, which isn't a lot of air, but it's enough to maintain normal gas concentrations in your bloodstream. So we call this tidal volume. Now, other volumes like our inspiratory reserve volume is calculated at the peak of tidal volume and then the deepest inhale you can make. That's inspiratory reserve volume. And you'd want to understand someone's inspiratory reserve volume because this tells you about, first of all, if their airways are obstructed or how compliant or stretchable their lungs are, right? And it's basically a measure of lung health. So people should have a normal range of inspiratory reserve volume. And if they're outside of that normal range, it could indicate some sort of pulmonary disease. Now, opposite to this, you guys, at the base of tidal volume, you can actually exhale to your maximal level. We call this expiratory reserve volume. It's your ability to expire, or basically exhale as much air out of your lungs as possible. But if you notice here, you can't get all of the air out of your lungs. Okay, and we call this residual volume. And the reason why this is, you guys, is that in order to get all of the air out of your lungs and out of your entire respiratory tract, it would require your entire respiratory tract to collapse, or basically break down, right? If there's any remaining spaces in your respiratory tract, then air will occupy that space. But we know that our airways don't collapse every time we exhale. So, and that's, because that's maintained by the tracheal cartilages and cartilages that support bronchi. But if those cartilages didn't exist, well then, you could potentially have a zero residual volume, but that would require your entire respiratory tract collapsing. So we do have some residual volume, which is important to consider because if someone's residual volume is high, then it suggests then they have difficulty expiring, okay? And they have a lot of excess air trapped in their lungs. But the reason why this is important, you guys, is that if that excess air gets trapped in your lungs, then it's not being properly ventilated. So now what that means is the next time you inhale, when you take the next breath in, right, back towards tidal volume, then you're mixing that kind of stale carbon dioxide-rich oxygen-poor air with the air you're inhaling. So overall, the air that's in your lungs then is going to have a lower oxygen content and a higher carbon dioxide content, right? So you want to try to avoid too much residual volume because it's going to affect your ability to ventilate, or at least participate in gas exchange. We call vital capacity, you guys, basically inspiratory reserve volume plus expiratory reserve volume. It's just a way to measure like total lung health. Think of vital capacity as being at the peak of your deepest inhale, and then exhaling all the way till you can't exhale anymore. That's vital capacity. And as we see here, it's around like between 5,000 milliliters or so 5 liters of air, which is actually a lot of air. But this is accounting for both lungs, not one lung. And then total lung capacity is just all the air that you can find along your respiratory tract. Now we'll come back to this sort of data later, you guys, because you can look at this data to figure out if someone has normal respiratory function, obstructive pulmonary disorders, or restrictive pulmonary disorders. So we'll come back to these data in a future chapter. Now, in terms of the mechanisms of breathing or ventilation, you guys, it requires these different forces here. First of all, we have opposing lung forces because our lung has a lot of elastic tissue. So the tendency for our lung then is to recoil to a resting shape. But what opposes that elasticity of the lung is the fact that lungs are anchored to a pleural membrane. And the pleural membrane or serous membrane around your lungs anchors your lungs to the inner thoracic wall, and it helps keep those lungs inflated, right? If your pleura was compromised and you didn't have it holding it to the inner thoracic wall, and let's say if it was ripped or torn, basically what that means is the elasticity of the lung then would cause that lung to collapse and shrivel up into this little ball of a lung somewhere in your thoracic cage. So we do have two different opposing lung forces. One that's sort of an inward pull of elastic tissue, and one that's an outward pull of serous membrane. Okay, and you want to have those things matched pretty well. What also plays a role in ventilation, you guys, is airway resistance. So going back to blood flow, we learned how flow was inversely proportional to resistance, right? If you decreased resistance, then you increased blood flow. And if you increased resistance, then you decreased blood flow. And it's the same mechanism here with breathing. If you decrease airway resistance, you're going to increase airflow. If you increase airway resistance, you're going to decrease airflow. Okay? And this relates to the diameter of those airways, right? We talk about like bronchodilation, bronchoconstriction. Well, if you bronchodilate, what's that going to do to your resistance? It's going to decrease the resistance, right? And if you decrease airway resistance, what does it do to airway flow? Increases it. Good. What if you bronchoconstrict, like during anaphylaxis or something? Right, it's going to decrease airflow because of an increase in resistance. So it makes it more difficult to ventilate, right? We also have lung compliance, which is the stretchability of your lungs. Like, how well do your lungs respond to changes in your thoracic wall, right? We know that while you're ventilating, your thoracic wall can expand during inspiration or inhalation, and it will kind of recoil back to a resting shape during exhalation or expiration, right? Well, just because your thoracic wall is moving doesn't necessarily mean your lungs are moving with it. And so there's something called compliance, which basically is the degree of stretchability of the lungs and how well they're able to comply with a changing shape of your thoracic wall. Okay? And there's things that can actually decrease compliance. So what do you guys think would happen if the lungs became less compliant or less stretchable and you try to inhale? So you take a deep breath, your thoracic cage expands, but the lungs are less stretchable. Right, they don't expand as well with the expanding thoracic cage, which means what's that going to do to airflow? Yeah, you're going to have less airflow. You might actually end up getting the same amount of air flowing into your lungs, but it could just take you longer for that to occur, which would be just more like laborious breathing, like taking a deep breath and just waiting for your lungs to kind of catch up because they're less compliant, and then eventually, an air will come into your airways, if that makes sense. And you'll see this with an obstructive pulmonary disorder. And we'll come back to that later. So just something to keep in mind. So this is what this picture is showing here, you guys. We have elastic tissue that's going to help our lungs recoil. And then we have our thoracic wall, which helps hold the lungs to the inner thoracic wall here. The tissue that connects the lung to the inner thoracic wall itself is serous membrane. We call it pleura. And this pleural membrane that surrounds each lung basically helps attach that lung to the thoracic wall, and it helps keep the lung open, or it kind of inflated, you might say. Okay, if that pleura gets compromised from like direct trauma or maybe just spontaneous damage, then your lung's not attached to the inner thoracic wall, and it might recoil to like this little, collapsed lung off the side or something. Okay, so something to keep in mind. Now we talked about airway resistance, and there's a relationship there. Remember how airway resistance relates to pressure and flow. So the resistance of an airway is influenced by its radius or diameter. So if you increase the radius and diameter of an airway, what's that going to do to resistance? Decreases resistance. What does it do to flow? Increases flow. Good. So if you give someone a bronchodilator, you're reducing their airway resistance, which can increase airflow. someone's in anaphylactic shock, you talk about giving them epinephrine. Well, epinephrine acts on beta-2 receptors of your airways to stimulate bronchodilation, so you can increase airflow by reducing resistance. All right. Now, airway can decrease. Like the airway diameter doesn't always decrease or increase due to smooth muscle, though. What you can find then is that you can have excess mucus buildup, which is kind of like bronchoconstriction. You can have bronchospasms, which are just sort of odd movements of the bronchi and bronchioles. Things like stress can lead to inflammation of your airway, as well as age can influence the diameter of that airway, either from excessive buildup of scar tissue or loss of tissue. So we'll come back to that later. Now, we know that our nervous system helps control airway diameter. And when we talk about airway diameter, it's really regulated by the autonomic nervous system, or ANS, right? So with the autonomic nervous system, we got our parasympathetic nervous system and our sympathetic nervous system. The role of the parasympathetic nervous system, this is rest and digest. So if you're resting, just kind of chilling, do you need a lot of airflow into and out of your lungs? No. So then the effect here of the parasympathetic nervous system on your airways is to bronchoconstrict, because you don't need as much airflow. The effect of the sympathetic nervous system, right, which is the fight-flight system, or remember the 3 Fs, fight, flight, fornicate. So if you're doing any of those 3, do you want airflow to be high or low? High, good. So yeah, you want to have an increase in airflow. So the effect of the sympathetic nervous system by acting on beta-2 receptors is to bronchodilate, to decrease resistance and increase airflow. We talked about lung compliance earlier, guys, and this is going to be the expandability or ease of lung inflation, and it provides an estimate of airway resistance and elasticity. So we said if someone's lungs were less compliant, then they're less stretchable, which means they have difficulty inflating or even deflating, which means it's more difficult to ventilate. So we'll talk about some disorders later that affect lung compliance, but for now, just know that compliance relates to the ease of stretchability. And you want your lungs to be fairly well stretchable, right? That way they can expand and contract during normal ventilation. What we find then is that lung compliance is increased in neonates and young children, and you see it decreased under conditions of increased chest wall rigidity, reduced mobility of ribs, sustained and partial contraction of different muscles, or loss of elastic fibers in the lung. All of these can decrease your lung compliance and make it more difficult to ventilate. And we'll talk about different diseases that affect lung compliance in more detail in a future chapter. Now, the mechanisms of pulmonary ventilation here, in terms of your nervous system, are regulated by your pons and medulla oblongata, right? So those are both aspects of your brainstem. So all you really need is a brainstem that's functioning appropriately to continually ventilate, right? As long as your pons is working and your medulla oblongata is working and the nerves associated with them are fine, then an individual will still ventilate on their own, okay? Now, the pons has respiratory centers that help regulate things like rhythm and the smoothness of rhythm, and the medulla has respiratory centers that regulate rhythm, okay? So you have multiple backup plans here, too. Let's see, even if the pons were damaged, if your medulla were still intact, which is the most inferior part of your brainstem, you could still potentially ventilate as well. So when you talk about conditions where someone loses their ability to ventilate due to brain injury or trauma, it's affecting their brainstem dramatically, right? And their brainstem is somehow damaged. And we'll talk about these sort of conditions later on in neurology chapters. Now, there are efferent fibers that carry information to muscles like your respiratory diaphragm, the intercostal muscles, and that those muscles are going to participate in ventilation or breathing, okay? So what this slide is showing then are some of the factors that influence the rate of ventilation. So if it's a plus sign, that means it's going to increase the ventilation rate. If it's a negative sign, that's going to decrease ventilation rate. So let's first start over here with receptors in muscles and joints. What we find then is that if you're using muscles more strongly and your joints are moving around quickly, which you'd expect to occur during exercise, this information about muscle stretch and joint movement is actually sent to the brainstem here, like the medulla oblongata, and just by moving those joints and using muscles, that itself can increase your ventilation rate. And it makes sense, right? Because if you're moving your limbs around really rapidly, then you're going to want to probably breathe more heavily because all of that requires work, or ATP. Okay. Other things like central and peripheral chemoreceptors can also influence ventilation rate. So if O2 levels are low and CO2 levels are high, then you're going to want to ventilate more rapidly, right? That way you can help eliminate that excess CO2 from your bloodstream and also absorb more oxygen from the air that you're inhaling. One thing that's important to note too is that ventilation is also one of the ways to help get rid of excess acid from your bloodstream. Okay, some acids, we call them respiratory acids, like carbonic acid, those can be eliminated through your lungs. So by ventilating more strongly, if your blood pH is too acidic, then you can help eliminate some of those excess acids from your lungs and help increase your blood pH or increase the basicity back to a normal level. Okay, and we'll talk about those conditions that influence things like acute respiratory failure. Otherwise, we have central chemoreceptors too, you guys. Like you find these in the meninges, like near your spinal cord. And these central chemoreceptors sense the carbon dioxide and acid content of cerebrospinal fluid, right? So these central chemoreceptors are going to respond to more like long-term changes in blood pH. And those can also, if your CO2 levels get too high or acid concentrations get too high, it can cause you to ventilate more strongly. We know that not all ventilation, though, is under like unconscious control, right? If you wanted to breathe more heavily, you can consciously control that. Or if you wanted to prevent yourself from breathing heavily, you can also consciously control that. And that comes from these higher brain centers here, you guys. So like the cerebral cortex is involved with more voluntary control over breathing. Like if I asked you guys to hyperventilate, you could just all of a sudden hyperventilate, right? So that's what this little positive sign means. Or you can also keep yourself from breathing. And you might wonder, well, when's it important to keep yourself from breathing? Well, especially if you're underwater. Like if you're diving underwater, you don't want to just start ventilating, right? Although it's automatic. But you can inhibit that urge to ventilate using higher brain centers, if that makes sense. Other receptors like pain or emotional stimuli can influence ventilation rate, right? So if you're in a lot of pain, that can increase the rate of ventilation. If you're really relaxed, that can decrease the rate of ventilation. So there are emotional factors to your ventilation rate. And then it turns out that we have stretch and irritant receptors in the lungs themselves. So the stretch receptors in the lungs actually prevent overstretch of your lungs. Because it's possible that you could actually inhale so deeply that your lungs overstretch and you end up damaging your lungs. So instead, what we find then are these stretch receptors in the lungs that once they sense enough stretch, then that sends information back to the medulla and actually inhibits your ventilation. So we call this the Herring-Brewer reflex, and it's a way to prevent overfilling of your lungs. So that's actually kind of cool. We also have irritant receptors along our airway, like on our trachea, carinae, and as well as the bronchi. Now, these irritant receptors also will inhibit ventilation, right? Like if you inhale something that's irritating, that will prevent you from ventilating more strongly, right? In fact, it's probably going to initiate a cough reflex, which is like the opposite, right? You're just trying to get all that gunk out of your airways now. Now, we talked earlier about how there's different types of pulmonary blood flow. We said it came from the pulmonary bronchioles. I'm sorry, the pulmonary arteries. I'm sorry, bronchial arteries, as well as the pulmonary arteries. And we're going to talk about this perfusion process next, you guys, where pulmonary circulation is more of a low-pressure circulation system. You know, it involves the right side of your heart. And we learned about how the right ventricle pumps blood to your lungs through the pulmonary arteries. But remember, the right ventricle was much thinner than the left. And although it pumps the same amount of blood as the left ventricle, it pumps it at a lower pressure, like it's a lower pressure system. It doesn't have to pump it as far. So it doesn't generate as much pressure as the left ventricle does. Now, pulmonary circulation pressure has a systolic pressure of 25 and a diastolic pressure of 8 millimeters of mercury. So it's a fairly low pressure system with respect to systemic blood pressure. These capillary beds that surround your alveoli are good for gas exchange, so absorption of oxygen and elimination of carbon dioxide into your airways. And so what's interesting, too, about your lungs, you guys, we mentioned this earlier, how not all of your lungs participate in the same amount of gas exchange. And not only does only 25% of your pulmonary tissue get perfused at any moment in time, but the different areas of your lungs also have a varying degree of ventilation or gas movement. So if you guys look up here, see how the superior lobe of this right lung is it's drawn a little bit more in a light color? What this suggests then is that it's actually getting less gas flow. So there's less airflow in the superior lobes, and there's more airflow in the inferior lobes. In fact, in the inferior lobes, you find a lot more smaller and abundant alveoli which means you have the most surface area down here. So the inferior lobes participate the most in gas exchange, whereas the superior lobes participate the least in gas exchange because, first of all, they get less blood flow and they get less airflow. And there's less surface area in the superior lobes. So this is important to note clinically because what if someone loses an inferior lobe of a lung? Well, that's one of their major lobes for gas exchange. So they're going to have more dramatic effects from that missing lobe than, let's say, if they had a superior lobe missing or removed. Okay. Now, ventilation perfusion rates, we mentioned earlier how your pulmonary system does a really good job at matching ventilation perfusion. So for alveoli that are really well ventilated, they're also very well perfused. And this is done by recruitment. So there's receptors in those alveoli that can sense whether oxygen concentrations are high or low. If the concentration of oxygen is high in an alveolus, this is the stimulus to increase blood flow to that alveolus. Okay? And the way you increase blood flow to an alveolus is by vasodilating the blood vessels that serve that alveolus. So some of our best ventilation perfusion ratios are about 0.8. So what this means is that you get almost a one-to-one relationship of airflow and blood flow. Okay, but ventilation perfusion ratios can be affected by shunting as well as like local regulation of perfusion changes. So what this slide is showing here, you guys, are just some abnormalities in ventilation and perfusion. So what if like a terminal bronchiole were plugged with mucus, right? That means that this alveolus would be poorly ventilated. And if there's any blood that's flowing to this alveolus, it's also not going to participate in a lot of gas exchange. So this can lead to hypoxemia, which is basically, low oxygen levels in the bloodstream. And that makes sense. So you wouldn't want to send a lot of blood flow to a poorly ventilated alveolus. And this decrease in ventilation could come from some sort of blockage, like mucus or even a foreign body, okay, or inflammation. What about if the blood vessels that serve an alveolus are not functioning properly? Like, let's say if they're damaged or destroyed, even if that alveolus were well ventilated, it might not be getting a lot of blood flow, which makes it sort of useless in that regard. Or what if that alveolus is collapsed, right? So what's the type of molecule that keeps our alveoli from collapsing? Surfactant, right? And how does it prevent our alveoli from collapsing? Good, yeah. Surfactant reduces the surface tension in alveolus, so it reduces the stickiness of water. And if you didn't make enough surfactant, that means your alveolar walls would be more sticky and they could stick together, kind of like what we're seeing here. So this could be an alveolus where maybe there's not a sufficient amount of surfactant being produced. And if this alveolus is collapsed, then you can bet that it's not getting a lot of airflow because it's collapsed. And so you're still going to get hypoxemia from this condition as well. So then what you can do then is actually, instead of sending blood flow to this collapsed alveolus, you can shunt that away and send that to a different area of your lungs. That way you can actually have the most efficient gas exchange. That's not shown on this slide, but it would occur. That's what we're talking about here, you guys. So you're going to get hypoxic vasoconstriction occurring if the blood vessels going to an alveolus remain hypoxic, like if they have low O2 levels. That suggests then that those alveoli are poorly ventilated, like they're not participating in gas exchange. So that we get then in result is hypoxic vasoconstriction. If you vasoconstrict, like if you constrict the blood vessels, then you're going to reduce blood flow to that alveolus, which then leaves that blood to available to go to some other alveolus that may be better ventilated. So the purpose of this is to divert blood to areas of higher oxygen concentration. And so the negative effects on gas exchange can be reduced if you do have any collapsed or blocked alveoli. Now, there's one other factor, too, that also influences the rate of gas exchange, and that's the thickness of the respiratory membrane. If you all remember going back to A&P, we learned about how the distance of diffusion is inversely proportional to its rate. And we talked about that as being Fick's law. And what this is mediated then by are all these different barriers that gases need to travel through. So for the gas or air that's in your alveolus, first of all, it's got to go through the surfactant layer that lines the inside of that alveolus. Then it has to travel through the alveolar membrane and the interstitial fluid into the bloodstream, where it needs to cross the capillary membrane into your blood plasma, and then finally enter a red blood cell. All of these are barriers for gas exchange. But the respiratory membrane is like half a micrometer, which is like 1/2000th of a millimeter in diameter. So it's a really, really small membrane, but by being very thin, then it allows for a rapid gas exchange. But if you have an increase in the thickness of any of these barriers, then it makes gas exchange less effective. Like what if you had way too much surfactant lining the inside of your alveoli? You had like a thicker fluid layer inside your alveoli. Well, it makes it more difficult then for gases to wiggle through, right? Or what if the alveolar membrane and interstitial fluid were inflamed due to some sort of inflammatory lung disorder? Well, that increased thickness would also make it more difficult for gases to cross. And that's what we're basically seeing on this slide, you guys. All of these different barriers like surfactant, alveolar membrane, tissue fluid of the lung, the capillary membrane as well, so the wall of that capillary, blood plasma, and the red blood cells, all of these are barriers against gas exchange. Now, this slide makes it look like it's thick, but like we said, this respiratory membrane is about 1/2000th of a millimeter in diameter, so it's very, very thin. And what that means is that gases can move rapidly across this membrane because it's so thin. And the law that helps us determine whether gases can move quickly across this membrane is called Fick's law. So Fick's law tells us that diffusion rate is inversely proportional to diffusion distance. So if you make diffusion distance longer or wider, then diffusion rate is slower. And if diffusion occurs more slowly, that means you're not getting a whole lot of gas exchange with every breath. So you can imagine that if someone had a condition where their alveolar capillary membrane was thickened, and this increased the diffusion distance, then they would have difficulty with the diffusion rate of their gases inside their lungs, and they would have, things like hypoxia. They wouldn't be able to help absorb a lot of oxygen from their airways. So what we find then, you guys, is that if what we can see then is actually disorders where if you have decreased available surface area, then that can decrease diffusion rate. But you can't increase diffusion rate by increasing with physical activity. But you see decreases in diffusion rate with elderly and newborn, and also if there's a mismatch between perfusion and ventilation. So this last part of this chapter talks about different alterations in pulmonary function, which sets us up for the next chapters. Because the next two chapters, we're going to talk about the restrictive and obstructive pulmonary disorders. So obstructive pulmonary diseases are going to be things that cause an increase in airway resistance. So things like foreign bodies that might plug airways, mucosal hypertrophy or thickening of the airway membrane, loss of structural integrity of the airway, or even narrowing due to increase in bronchial smooth muscle contraction, where there might be hyperactivity of that muscle. All of these are obstructions, okay, whether they're intrinsic or extrinsic obstructions, and these make it more difficult for air to flow because they ultimately reduce the available cross-sectional area of your airways, which increases the resistance and decreases flow. So it makes it more difficult to ventilate with these obstructive pulmonary diseases. What's interesting, though, you guys, with all these obstructive pulmonary diseases, they don't typically affect your vital capacity that significantly, though. Remember, vital capacity was the total amount of air you can inhale and exhale. These obstructive disorders don't affect vital capacity as much as the restrictive disorders. It just takes you longer to exhale or inhale, but you'll get there. It just takes you a little longer because of that obstruction, right? And that kind of makes sense. Now, hypoventilation means low or slow ventilation rate. You can imagine if you're ventilating very slowly and the gases are moving into and out of your airway more slowly, that means you're not absorbing oxygen as quickly, nor are you releasing carbon dioxide from your bloodstream into your airway as quickly. So with hypoventilation then, we define this as that where air is delivered to alveoli insufficient to provide enough O2 to your body's tissues and remove CO2 from your bloodstream. Okay? Hypoventilation or slow ventilation leads to an increase in the CO2 levels in your bloodstream, and we know that leads to an increase in the acidity of your blood or a decrease in the pH, and it also causes O2 levels to be low, so we call this hypoxemia. Some different causes of hypoventilation could be things like morphine, barbiturates, obesity, myasthenia gravis, sleep apnea, chest wall damage, paralysis of respiratory muscles, or even surgery to the thorax or abdomen. Because if you had surgery and you're in pain, it's going to prevent you're not going to want to breathe because every time you breathe, it's going to be painful, right? So that could lead to hypoventilation. And it makes sense. If you're hypoventilating, CO2 levels are going to build up inside your bloodstream, right? Because you're not eliminating that CO2 as well. That's what's going to cause this increase in the PaCO2. And nor are you absorbing as much oxygen. So you're going to see hypoxemia or low O2 levels in the blood. This differs from hyperventilation because hyperventilation is really rapid breathing. But hyperventilation is defined as rapid and deep breaths, not rapid and shallow breaths. So if you're rapidly breathing deeply, what that means then is you're getting a lot of airflow into and out of your lungs. And this is not always necessarily a good thing either, guys, because if you eliminate too much carbon dioxide from your bloodstream, then that makes your blood pH too basic, right? And we call this hypocapnia, and that can actually alter your blood's pH. Or you might absorb too much oxygen, okay? And but hypocapnia is more of the damaging disorder here, where by having low CO2 levels in the blood, it makes your blood's pH less acidic or more basic, and that could potentially bring you to, fatal areas. If your blood's pH gets above 7.8, that's a fatal condition. Normally your blood pH should be between 7.35 and 7.45, but if you're hyperventilating, you can actually start to eliminate too much acid from your bloodstream. And that can start to change the shape of proteins in your blood and throughout your body, which could eventually be fatal. But some different causes of hyperventilation could be things like pain, fever, anxiety, obstructive and restrictive lung diseases, sepsis, high altitude, or brainstem injury. In fact, one of the symptoms of hypocapnia, guys, due to a change in your blood's pH, or what we call paresthesias, or tingling. And you may have noticed this sometimes, like if you are exercising, you're breathing really heavily, just to get enough oxygen in your bloodstream. You can eliminate too much carbon dioxide, and you start to get like tingling in your fingers and lips. We call that paresthesias. That comes from a blood pH that's too basic, and it starts to alter nerve function. So it's kind of interesting. Now, hypoxemia is the word we use to describe deficient blood oxygen, and that differs from hypoxia because hypoxia is where we have a decrease in tissue oxygenation. These aren't the same though. So hypoxemia is low O2 levels in blood. Hypoxia is low O2 levels in tissue, right? And they're not the same because how could you get a decrease in tissue O2 levels without a decrease in blood O2 levels? Can you guys imagine a circumstance where that might happen? With exercise, where maybe if your tissues are using up oxygen so quickly that you get hypoxia in the tissue, but you might still have normal O2 levels in your bloodstream. It's just that it's not diffusing rapidly enough. That's a nice hypothesis. I like that one. Or what if you blocked a vessel, right? Downstream of that vessel, the tissue will become hypoxic, but that doesn't mean your entire bloodstream has hypoxemia. It just means that the tissue doesn't have enough oxygen. So just different words to describe the state of oxygen in different areas of your body. Now, some different types of hypoxia could be things like hypoxic hypoxia. You get this from high altitude. In fact, I had this the first time I ever came to Colorado. I was like thinking about moving here, and we're like, hey, let's go take a trip to Colorado. So we came out here and went skiing. And I was up at Vail. If you guys have ever been to Vail, there's a lot of areas where you get the cat tracks to get from one area to another. Well, snowboarding, I had to kind of kick my foot to get from one place to another. I didn't have ski poles on me, right? And I was kicking my foot. I didn't realize that I'm not like 10,000 feet or higher, right? And I ended up getting like hypoxic hypoxia and had really bad paresthesias, and like my fingers were tingling, my toes were tingling, my mouth was kind of numb, and I felt really lightheaded, because I was from that low O2 levels from high altitude, right? There's lower concentration of O2 at higher altitude, so that's caused by hypoxic hypoxia. And then I also thought I had pulmonary edema, but that's probably just me being weird. Anemic hypoxia, guys, comes from low hemoglobin. We've already talked about the causes of anemia earlier. Circulatory hypoxia comes from shock or low cardiac output, and histotoxic hypoxia comes from a decrease in O2 carrying capacity. Things like cyanide poisoning. Okay, so cyanide blocks the electron transport chain in your mitochondria, and it prevents oxidative phosphorylation, and we call that histotoxic hypoxia. So it's kind of interesting. Now, there are different conditions where you might have normal perfusion but low alveolar ventilation, right? Like where your lungs are getting enough blood flow, but they're not getting enough airflow. And so some causes of this could be like atelectasis, which is partial or complete collapse of your lung or airway, or pneumonia or acute respiratory distress syndrome, where you might get enough blood flow to your lungs, but if airflow is diminished due to a blockage or a collapsed airway, then that can lead to hypoxia and hypoxemia. Otherwise, opposite to that, you guys might find a condition where you have normal ventilation but low perfusion, right? So if your ventilation's normal, like you're breathing normally, but there's low blood flow to your lungs, that can still lead to hypoxemia and hypoxia, because this can be caused by things like pulmonary emboli, things that block blood vessels, which would reduce blood flow to the lungs. Lupus, because that's an inflammatory disorder, which can also lead to a decrease in blood flow to your lungs. Sarcoidosis, which we'll talk about later today, or even alveolar carcinomas, where cancer might block, a particular blood vessel. So it's kind of interesting. Now, we define acute respiratory failure as PaO2 levels, so blood O2 levels less than 60 millimeters of mercury, CO2 levels greater than 50 millimeters of mercury, and a pH less than 7.3. If you had respiratory failure, why would your blood pH be more acidic than normal? Nice, you're not getting rid of CO2. Back in A&P, we learned that CO2, when it dissolves in water, can form carbonic acid. But if you exhale CO2, then you're basically removing carbonic acid from your bloodstream. So if you have respiratory failure, then your blood's going to be more acidic due to an accumulation of carbon dioxide in the blood. We define this as a pH less than 7.3. Okay? But normal blood pH is 7.35 to 7.45. It's a very narrow range of blood pH. There's different categories of respiratory failure, guys. It could be a failure of respiration, right? So a failure of gas exchange. It could be a failure of ventilation, or a failure of airflow, or a combination of both, right? You might have a difficulty with gas exchange and airflow, so failure of both respiration and ventilation. So some causes of acute respiratory failure can be things like central nervous system problems or neuromuscular diseases, chest wall and diaphragm dysfunction, pulmonary parenchymal diseases like diseases of the lung tissue itself, or even airway problems. Some of the clinical manifestations of this will be, for one, hypoxemia. We could guess that, right? Low O2 levels in the blood. Hypercapnia, which means high CO2 levels in the blood. That makes sense. Headache due to disturbed pH levels. Dyspnea, shortness of breath. That makes sense because you're trying to, basically exhale as much CO2 as possible. Confusion and decrease in consciousness due to changes in pH. Agitation, dizziness, restlessness, all these neurological symptoms come from a decrease in pH. When your blood pH becomes more acidic and there's low O2 levels, your brain tissue can't function normally, so you see deficits in cognitive function. Early on, you'll see rapid shallow breathing. Later on with respiratory failure, guys, this can lead to things like cyanosis, nasal flaring, as well as retractions, because you're just sort of struggling to inhale as much as possible. This is diagnosed by blood gases, electrolyte panels, blood counts, that kind of stuff. The treatment for respiratory failure would be maintaining airway, keeping ventilation, high. This can be done mechanically using like an iron lung. We'll talk about that later. Treating underlying problems, like if it's due to blood pressure problems, you might treat that with like a diuretic if necessary. If it's an inflammatory disorder, you can treat this with a steroid. Otherwise, you might require nutritional support, supplemental oxygen, like you see that in football players playing here at Denver, or antibiotics if there's an infection, right? Did you guys see the game last weekend? And like people are just like sucking on these oxygen tanks. And they're even on the Denver side, right? Which just tells you how low our oxygen here is. Pulmonary hypertension, or basically high blood pressure, is it where you have a sustained pulmonary blood pressure that's greater than 25 millimeters of mercury. Why is this bad? Why don't you want your pulmonary blood pressure to be too high? What can that cause if your pulmonary blood pressure is too high? Yeah, pulmonary edema. You're basically going to force fluid out of your blood vessels into the lung tissue and possibly even the airways of your lungs. So you want to keep pulmonary pressure from being too high. What might be some causes of pulmonary hypertension? Maybe systemic hypertension, where blood's backing up in the heart. So you can kind of think of this as almost like left-sided heart failure, where let's say if your systemic diastolic pressure is really high, and so then you have a decrease in stroke volume, your left ventricle can't pump as much blood out. That means that blood's backing up into the lungs, and that backup of blood in the lungs is going to increase lung blood pressure by increasing resistance. And so that can lead to pulmonary hypertension. You're right. So systemic hypertension can lead to pulmonary hypertension or even left-sided heart failure, because if the left side of the heart can't continue to move blood along, then that blood's going to back up in the lungs and lead to hypertension. Some of the pathogenesis, you guys, of pulmonary hypertension is that initially what you'll find is that the walls of small vessels can thicken from an increase in mucus. Internal layer of the pulmonary arteries can also become fibrotic and narrowed. And sustained pulmonary hypertension can cause a plexiform network to form, which actually impedes blood flow. So it makes it more difficult for blood to flow adequately through the lungs, and that actually increases pulmonary hypertension even more. So it's sort of this positive feedback mechanism here. Now, pulmonary venous thromboembolus is basically, we've talked about this before, it's basically where a blood clot can form somewhere in a distal extremity and then eventually travel to your lungs through systemic veins to the right side of your heart, and that can get pumped to your lungs, right? So this can be made of blood clots, fat emboli, amniotic fluid, air, tumor, foreign bodies, sepsis, or even like masses of parasites can block your lungs. And when it includes these vessels, or occludes the vessels, that basically can restrict blood flow. So you can see, perfusion problems from that. Now, 90% of these pulmonary venous thromboemboli, though, you guys, occur in the veins of your extremities, right? So they can start somewhere else, like maybe a larger systemic vein, the right side of your heart, or even a pulmonary vessel. But most often, you guys, they come from deep veins and lower extremities. And the risk factors for thromboembolus, we talk about Virchow's triad. So Virchow's triad, it refers to the factors that can promote blood clotting, abnormal blood clotting, right? So disorders of hemostasis. So what we might find then is that one of Virchow's triad is venous stasis, or sluggish blood flow promotes clots. So what are some conditions that might promote sluggish blood flow, like in an extremity? Yeah, if disuse. So why might someone not be using an extremity then? What's that? Yeah, after a surgery or something, and they're bedridden, right? Or they're paralyzed, or they're sitting in class for 6 hours listening to pathophysiology lecture, right? That can lead to venous stasis or sluggish blood flow, which could lead to blood clots. Hypercoagulability, you guys, which can come from things like vitamin K excess, or we talked about different clotting factor disorders earlier, or even damage to the venous wall. So if you get like maybe a bruise on the extremity and that damages the wall of a vein, we call this intimal injury. That can lead to the formation of a blood clot, which might turn into an embolus, which can actually lead to blockage of a vessel in the lung. Some risk factors for pulmonary venous thromboembolus, though, you guys, would be things like, for one, immobility. That makes sense. Trauma, pregnancy, cancer, heart failure, and even high estrogen use. So if you're taking a lot of estrogen, because there's actually estrogen receptors on platelets, and that promotes blood clotting. Okay. What's not up here too, you guys, is progesterone use also promotes blood clots, as well as smoking also promotes blood clots. So you can add on to this risk factor. So the pathogenesis of these thromboemboli, you guys, is basically the thrombus will be dislodged from its vein or point of origin by either direct trauma, exercise, muscle action, or changes in blood flow, where you might just have a thrombus, but if it dislodges, it turns into an embolus, and that can turn into an embolism. But if it's occurring in a systemic vein, the first place it's going to go is to the right side of your heart, which then pumps blood to your lungs. So it's most likely going to lodge in lung tissue somewhere. And this can be fatal if it's severe enough. Now, last slide here for this chapter, we're going to talk about the pulmonary malignancies. And there's different types of basically lung cancers. We got large cell, small cell, squamous cell, and adenocarcinomas. Large cell carcinomas are more likely to develop in the periphery of the lung, like outer edges of the lung. Small cell carcinomas most likely develop in the central bronchial region. Let's think of like the medial aspect of the lung. Squamous cell carcinomas also come from the hilar region, or the medial aspect. And the adenocarcinomas are the most common type. Those occur in the peripheral lung tissue. And it's the adenocarcinomas that are associated with smoking-related lung cancer. And adeno means it's associated with glandular tissue. Think of like a mucus gland, right? And if these things actually become cancerous, then we call that adenocarcinoma. The clinical manifestations of lung cancer are really just going to depend on the type and location of that lung cancer. They can be totally asymptomatic. My grandfather has, it's not cancer, but it's a benign growth in the inferior lobe of his right lung. and it's totally asymptomatic. He didn't see it until we went in for a chest X-ray. Luckily, it's not growing. In fact, it appears to be shrinking. But the thing was the size of a baseball. It's on his right lung, but there's no signs and symptoms at all, right? However, if that were closer to the hilar region, where you find larger airways, if it starts obstructing the airway, you can start to see signs and symptoms of that pulmonary malignancy. In fact, one last thing I'll mention to you guys is that another sign of lung cancer, if the lung cancer is on the superior lobes of your right or left lungs, it might impinge on a nerve. There's something called the recurrent laryngeal branch of your vagus nerve. This thing goes down your neck, and it's a branch of cranial nerve number 10, vagus nerve. It goes beneath your clavicles over by your lungs. Then it goes back up towards your larynx, and it's what you use to speak. So if someone has a cancer or a growth on a superior lobe of their lung, and it's impinging on that recurrent laryngeal nerve, then they can start to have speech difficulty. You might have like hoarseness of the voice or difficulty speaking or pronouncing words, that kind of stuff. So that could actually be a manifestation of lung cancer, which is interesting.